A post-op cataract surgery patient come 3 days after surgery with severe pain, watering and discharge. His vision is counting finger and there is conjunctival congestion, corneal edema, hypopyon and yellow fundus reflex with no retinal view. And BScan shows vitreous activity. Now it's a clear-cut case of endophthalmitis because the telltale signs are that it is poor fundal growth. BScan will show vitritis, severe vitritis, vision will be hand movements, counting fingers or 660, and recent surgery, cataract surgery will be done. So questions 17, 18, 19 are related to this scenario, and the answer to question 17 is endophthalmitis. In hyphema you will have blood. In acute congestive glaucoma there will be mention of intraocular pressure. Now what is the investigation of choice? You should know the cause of endophthalmitis, and for that vitreous tab for culture is the answer. CT orbit, MRI orbit, they are of no use because the infection is within the confines of the globe. Blood cultures will also yield no result and FBC is not needed. Now what is the best treatment option? Definitely the source and the site of infection is vitreous, so intravitreal antibiotics should be given. So the answer is A. Systemic steroids, oral anti-VEGF steroids, they have got no or minimal role. Now a newborn baby of 3 months age is brought to eye with complaints of watering, photophobia and large sized eye. Now regurgitation is negative, so NLD is ruled out. Corneal diameters are 11, so these are enlarged, but cornea is clear. Optic cupping is 0.5, intraocular pressure is 28. When pressure is raised, it is a case of congenital glaucoma. In congenital glaucoma, you can have a hazy cornea or clear cornea, and management will depend upon the condition of the cornea. Like here, the cornea is clear, so the treatment of choice is goniotomy. In clear cornea, we do goniotomy. In hazy cornea, we do trabeculotomy, and when the pressure is not maintained with goniotomy or trabeculotomy, then we do filtration, anterior filtration or trabeculectomy. Probing should be done in the case of congenital NLD block, which is not the case. Corneal transplant in a hazy cornea is done, which is here the cornea is clear, and topical antibiotics in the case of infection, conjunctivitis. Now a female patient presented with sudden painful loss of vision in her right eye with halos. Vision is counting finger. In the affected eye there is circumciliary conjunctival congestion, corneal edema, anterior chamber is shallow and pressure is very high, 55. So it's a clear-cut case of acute angle closure glaucoma, one of the most important ocular emergencies. It is not uveitis. In uveitis you can have raised IOP, but not that much. It is not the keratitis as well. Now how will you treat her right eye? Topical steroids, cycloplegics, topical anti-glaucoma, atropine, IV mannitol or topical antibiotics. As we have already said that it's a case of angle closure acute with very high pressure, so the answer is IV mannitol infusion because the pressure is very high and it will not be decreased with the topical anti-glaucoma drops. Now the next question 24 is that how will you manage left eye, because the other eye will also be predisposed to angle closure attack. So we can do prophylactic YAG laser peripheral iridectomy in the fellow eye. So the answer of question 24 is B, YAG laser PI. Now, which of the following anti-glaucoma belongs to carbonic anhydrase inhibitors group? Betaxolol is beta blocker, bimetoprost is prostaglandin analogs, brimonidine is alpha agonist, darzolamide belongs to carbonic anhydrase inhibitors group, pilocarpine is parasympathomimetic. So you should know. A 20 years old tall patient presented with gradual, painless and progressive decrease of vision in both eyes. Vision is counting finger. There was bilateral superior dislocation of the crystalline lens. So check here is tall patient, male, 20 years old, counting finger and superior dislocation of both eyes. Both eyes dislocations. Unilateral dislocation goes towards the trauma. Bilateral means some systemic disease. So all the features with thin long fingers and long limbs, high arched palate. So diagnosis is Marfan syndrome. A 6 years old child is brought to eye OPD by his parents with history of white pupillary reflex leukocoria. And there is oil droplet type of congenital cataract. So leukocoria is due to congenital cataract and congenital cataract is of oil droplet type. So in which disease oil droplet cataract occurs? Well, in galactosemia you can have oil droplet type of congenital cataract. Now, a young female presented to you with complaints of redness, ocular pain, stinging sensations in last 2 days. There is no discharge. The right eye is normal. Left eye has got sectoral area of pinkish discoloration of the conjunctiva, which moves freely over the sclera. So, freely movement means it is not scleritis. And sectoral area. So sectoral area is involved in episcleritis. So that's the answer is B. Now 21 years old male patient presented with decreased vision in both eyes with history of frequent glasses change. A retinoscopy shows scissor reflex, ophthalmoscopy show oil droplet reflex, and there is bulging of the lower lid when patients look downwards, which is a Munson sign. So what is the name of the sign given at the end of the scenario? So it's a Munson sign. Walked lines are stress lines on the center of the cone. Fleischerlings is the iron ring. Acute heart drops is the sudden opacification. Now, what is your most probable diagnosis? Well, the diagnosis in that patient is keratoconus. Corneal dystrophy will be bilateral. Band keratopathy will have a band-shaped lesion on the cornea from 3 to 9 o'clock. Spheroidal degeneration is totally different, and in old age, keratoglobus will have a diffuse bulging of the eyeball, and it is a case, the most common ectasia and the most important ectasia, corneal ectasia. So the answer is keratoconus. Now, what is the definitive treatment of this disease at the end stage? At the end stage, there is corneal opacification. The vision is irreversibly reduced, and you have to replace that cornea with a healthy donor cornea, and that process is known as keratoplasty. Collagen cross-linking is done in a progressive keratoconus when the vision is not that much decreased. Intex is also done early on. BCL and corneal scraping has no role. Now, a 40 years old patient presented with ocular pain, photophobia and watering since last 4 days. There is a branching type of epithelial defect on cornea. On cornea, branching type epithelial defect, so it's a viral keratitis. It is not fungal, it is not bacterial, it is not acanthamoeba, it is herpes simplex keratitis. It is also not Muran, which is an autoimmune keratitis that occurs at the limbus. Which one of the following topical drugs is contraindicated in this disease? Well, steroids are contraindicated in epithelial viral keratitis because it can worsen the disease, and the disease can convert from branching dendrites into geographic viral keratitis. A 30-year-old lady presented with bilateral watering and foreign body sensation in both eyes since last 1 month. On examination, large furacles on upper tarsal conjunctiva and vessels in the upper part of her corneas. Now, what is the most probable diagnosis? So, it's the patient have got follicles in the conjunctiva and vessels in the upper part of her cornea. So, the diagnosis is trachoma. A 70-year-old male patient presented with gradual enlarging mass on his left lower eyelid. Very old age, gradually enlarging mass. On examination, it was a nodular lesion with ulceration and rolled margins. So, what is your most probable diagnosis? So, the most probable diagnosis is basal cell carcinoma. 56-year-old lady had Calazian surgery few months ago, and now there is a recurrence on her upper eyelid. There was a nodular lesion with loss of eyelashes in that area, and it was painless. So, what is the most probable diagnosis? So, recurrent Calazian and eyelid margin anatomical texture is disrupted. So, the most probable diagnosis is some malignant lesion and of that of meibomian gland. So, sebaceous gland carcinoma is the most probable diagnosis. A 35-year-old female presented with watering and swelling of the right medial canthal area since last 3 days. There was swelling with redness and tender touch, and patient had similar episodes in the last few years. So there is a history of chronicity, and now she presented with acute infection. So the most probable diagnosis is acute on chronic dacryocystitis. Calcite will be tender, enlarged, red, blepharitis will be something else. Now, how will you treat this patient? Well, at the moment she has got acute dacryocystitis, so treatment will be oral antibiotics plus painkillers. DCR will be done when the acute infection subsides. Probing and syringing is contraindicated. So, what will be the definitive treatment? Well, definitive treatment is definitely dacryocystorhinostomy. You cannot observe it, you cannot do incision and drainage, and you cannot do close intubation or probing and syringing in this case. An uncontrolled diabetic patient was referred to you by endocrinologist for diabetic retinopathy screening. So, vision is 6/6. Bilateral anterior segments normal. Fundi show bilateral proliferative diabetic retinopathy with new vessels on the disc, while fovea was normal. Now, how will you treat this patient? Observation and close follow-up. Now, she has got proliferative diabetic retinopathy, so you will do pan-retinal photocoagulation. A 60-year-old hypertensive patient presented with sudden painless loss of vision in her left eye 2 days ago. On examination, vision is 6/12 and counting finger in the left eye. Cataracts are mild. Right fundus is normal. Left show retinal hemorrhages, cotton wool spot in the superior-temporal quadrant with macular edema. So, it's a case of branch retinal vein occlusion. In a branch retinal artery occlusion, you will have a pale fundus with the cherry red spot, but hemorrhages cotton wool spot shows that it's a venous occlusion. And what is the investigation of choice? OCT macula, to know how much macular edema is present, and then accordingly we will treat this patient. Now, what is the best treatment option? Well, intravitreal anti-VEGF can be performed in a macular edema of branch retinal vein occlusion. Mild cataract, so there is no need of cataract surgery. Laser photocoagulation is done when you find new vessels. A 65 years old non-hypertensive and diabetic presents severe pain in his right eye since last 7 days. Vision is perception of light in the right eye. There is corneal edema, shallow anterior chamber and iris new vessels. When you find iris new vessels, it means that it's a case of new vascular glaucoma. Other findings will be oval mid-dilated pupil, no fundus view, and intraocular pressure will be 48. An uncontrolled diabetic patient presented to you with diplopia, double vision, and his left eye was esotropia. There is diplopia and the eye is in esodiation. It means there is abduction deficit in the left eye. So the most probable diagnosis is that the sixth nerve is damaged, and that has leads to esotropia. And which muscle is involved in this case? Definitely lateral rectus is involved, so option is C. So I hope after watching this video your concepts will be cleared and it will help you in the final exams. Thank you very much.